Hello and welcome to this session of Risk Awareness Week 2022. You need quantitative risk metrics to effectively measure and manage risk. Thank you so much for choosing to invest your time in this presentation, and a very particular thank you to Alex Sidorenko for asking me to submit the proposal for this. This is my first venture outside of my normal arena of the medical lab technology, and I really hope that you will get in touch with me to say, was this a wise investment, and how do you think today's information might be helpful to you? Before we start talking about where I want to get you to today, I want to give you a little look at where I'm coming from, because I literally took the path less traveled. I'm from Canada, specifically Ontario. I trained in Toronto, and for 10 years I worked at a small hospital about an hour away from there, where I was a hospital department head. Was there I studied for my advanced registered degree in medical technology. We brought in computers for the first time. We brought in Westgard rules. And then I left there for a brief stint in Toronto before going back to my beloved north to 6 hospitals north of Sudbury in the Cochrane Region Lab program. Here we again brought in computers, quality control. These were the Wild West days of computers. Everything was in DOS and done by teleconference, but the entire focus was on quality improvement. I had a budget. I could attend conferences. In 1991, I was able to co-present a workshop, a full-day workshop with James Westgard in Montreal. It was here that I began developing software so these people could have a way to make good decisions when I wasn't there. I was able to conduct studies with labs around the world and lecture to labs around the world, and found there was a consistent global problem in what was wrong with quality control. All of this has happened from this 500-acre farm in northern Ontario and led eventually through a rather bumpy road to awesome numbers, the company I am now with and proud to say I am co-founder and CEO of. You need quantitative risk metrics to effectively measure and manage risk. So we're going to talk about new software to manage risk in medical labs and beyond. My background is medical labs, but I believe this will work essentially anywhere. In the medical lab field, risk is the combination of the probability of occurrence of harm and the severity of that harm. Probability of harm can be measured as the number of failures, I call them medically unreliable results, per year that place patients at risk of missed or delayed diagnosis or treatment and place institutions at risk of litigation. Severity of harm can be measured by the cost of that. What does it cost for all of these excess procedures? How does medical lab quality create risk for you? It all starts when you go to the doctor who orders a blood test to diagnose or treat an illness. People then use complex instruments and chemicals to create results. Many things in that process can go wrong, and they always do go wrong to a lesser or greater degree. The problem exists when the size of error is so great that your results get put into the wrong pot. The doctor thinks that no action is required when they should be doing more tests or acting now, or any one of these. If you don't end up in the right pot, you are at risk, and healthcare costs will increase. It's intuitive that lab error adds risk of harm and cost to patients and health care. This was first published in 1981, where they listed the events and consequences resulting from lab error, going everything from nothing to repeating tests or a battery of tests to unnecessary hospital utilization to patient disability to death. Something that is rather unique within medical labs and labs in general is they use surrogate controls to manage risk. Unlike industry or manufacturing, where you take your widget off the line and you weigh and bend and twist and check that widget to make sure it meets customer specifications, in the medical lab, we use what is essentially a freeze-dried sample to make sure the system is working. Typically, labs test 2 quality control samples in the morning, run anywhere from 10 to 1,000 to 2,000 samples during the day, and if you're lucky, they repeat another 2 samples to make sure everything's okay before reporting those patient results. That's really the only way that you can guarantee that no errors are reported. Risk management is incredibly simple. You define acceptable risk as the probability and severity of harm. You measure risk as the number and cost of harm currently and if the system was to fail unexpectedly. You then ask yourself, is the current risk acceptable? Is risk acceptable now? And would risk still be acceptable if the system failed tomorrow? Is my daily QC effective enough to detect that failure? It's all spelled out for us in this document, Laboratory Quality Control Based on Risk Management. Risk is defined as the combination of the probability and severity of harm. Risk evaluation is the process of comparing how much risk you've got to how much risk you're allowed to determine if risk is acceptable. If you can define acceptable risk, the computer can collect the QC data, it can measure the number and cost of lab error, it can advise where you need to improve accuracy or precision, it can project how much money you're going to save, it can evaluate the effectiveness of your daily QC process to detect unexpected failure, and it can give you a verified effective QC process that is guaranteed to maintain acceptable risk. We have established these 3 facts. Now we need to ask how much error is allowed, what makes results medically unreliable. Then you need to measure the probability of harm as the number of medically unreliable results, measure the severity of harm as avoidable healthcare cost, and answer the question, is risk acceptable? What do I need to do? Error is a deviation from truth, accuracy, or correctness. Every lab result has some degree of error. An incorrect result, however, is a result that does not meet the requirements for its intended medical use. In the case of a quantitative test procedure, a numerical test, which is all we're talking about, a result with a failure of measurement that exceeds a limit based on medical utility. If it's a qualitative positive no test, you got to get the right result. Allowable limits of error are the amount of error that can be tolerated without invalidating the medical usefulness of the analytical result. I call these incorrect results MURs, medically unreliable results. Sorry to throw a new term at you, but it really is so much simpler and more intuitive than saying a result that fails a total allowable error limit. To answer the question of how much error creates risk, or how do you define your total allowable error limit, you have two choices. You can choose the regulated limit. Choice B is to determine medical opinion of the limit based on medical utility. We're not going to talk about this anymore. Just do this. It makes sense, and this is what we did back in 1991 when I was starting to do this. I sat down with the lab director, said, how much can this control vary from its existing true value of X before the doctor is going to make a different medical decision or take different action? And he gave me numbers which we then compared to CLIA, and they were remarkably close. With this in mind, you can measure the probability of harm as the number of medically unreliable results and the severity of harm as the healthcare cost. You start by measuring the mean and SD of 15 to 50 QC replicates. You define a true value and a medical goal for each QC sample. The final step is to define current acceptable risk levels as the acceptable probability and severity of harm. You're asking, what numbers am I getting? What numbers do I want to get? Stop and fix if the error rate exceeds this, or if the cost of off-target products exceeds that. Once you've filled in these risk drivers, you will see a display of what I call risk bells that show the current risk as accuracy and precision against your allowable error limits. You also get numerical results. This is the z-value, or the sigma value, of 6.0. The margin for error, how far you can move before risk becomes unacceptable, is only 3.0. The acceptable number of medically unreliable results per year is 49, based on 3 sigma, which is 0.135%, times 100 patients a day times 365 days a year. You're currently producing 0 errors a year. The average healthcare cost per patient result reported for all of the patients you report is $14. If the measured mean increases, so it shifts up by 1.5 SD from 100 to 103, if the measured mean was to shift from 100 to 103, you can see that the curve of the QC data shifts upward. The new mean is 103. The standard deviation hasn't changed. The z-value, or sigma, goes down from 6 to 4.5. The margin for error goes down. The acceptable number of results per year stays the same. You're still not producing any errors. The cost, however, has increased as the mean shifted away from the true value and towards the allowable error limit, because the cost at the failure of the allowable error limit was set at $100. It would be 0 if you're right on the true value, and here the average cost of error would be about $26. We'll take this as our starting point and say what would happen now if the mean was to shift from 103 by just 1 standard deviation up to 105. Our z-value used to be 4.5, or sigma. The margin for error until risk became unacceptable was 1.5. Now, this method can only shift 0.5 standard deviations before it's in trouble. You can imagine that it's more difficult to maintain quality on this method than on this method. This time, the number of medically unreliable results per year has gone up from 0 to 9, and the average healthcare cost per patient result reported is $42. We take that as our starting point. Now you're seeing a risk-based quality grade come up, and you can see that this is grade D, which means it's getting close to its failure rate. You should have a look at it. If the measured mean was to increase up to 106, this would become a grade F, because now both the number and the cost of error are unacceptable. You can look at the statistics if you want. You can see that the z-value is 3 and the margin for error is 0 and the total error is 10%, but you can just look at this great big risk-based grade, the number and the cost of errors. Moving on from this case, which remains now at the top, my measured values, true value, and TEA limits stay the same. You control the acceptable probability and severity of risk. In this case, I increased both of them. I went from 3 sigma to 3%, and I went from $50 to $60. Now, although my curve is in the same place, it's no longer a grade F, it's a grade C, which means the risk is acceptable now. Quality control needs improvement. My acceptable number of errors per year went from 49 to 1,095 at 3%. But I could have just as easily set this at 3 medically unreliable results per year, in which case this definitely would have failed. If I increase the SD from 2 to 3, it now becomes a grade D. The sigma value goes down to 4, the margin for error goes down to 1, the number of medically unreliable results per year goes up to 2, and if the SD increases to 4.0, it then fails because it's going to produce 99 medically unreliable results per year. That answers the question of how to measure the probability of harm as the number of medically unreliable results per year. The next question is, how do you measure severity of harm and set an acceptable level? You can try to approach it from statistics, or you can measure it as the additional health care cost. How do we make that connection? That journey began 40 years ago as a method of determining costs associated with lab error. At that time, they simply asked clinicians to estimate how much it would cost if a bad result was reported. The National Institute of Standards and Technology performed a study that was reported in 2004 where they actually looked back at 89,000 patient charts and said, what did the doctor order and what did it cost when the calcium result was X? They found 26 tests or procedures where the probability of that being ordered was proportional to the level of the calcium result reported. This is what would happen if the doctor thinks it's hypercalcemia. If the calcium level is low, these are the tests that might be ordered. As the calcium level increased, costs increased from $650 per patient to $1,100 per patient to $1,800 per patient, And this is the amount of error allowed yet by CLIA, plus or minus 1 milligram per deciliter, or 0.25 milliequivalents per liter. Based on their analysis, they said an analytical bias of 0.5 milligrams per deciliter would result in a potential health care increase from $34 to $89 per patient in the United States having a calcium test. They found that the cost of error increases with the size of the calcium result. So the cost of avoidable tests goes up even as the result increases within the allowable error limit. This data set represents a 6 sigma population. They are 6 standard deviations from the allowable error limit. If your patient population instead looked like this, oh, okay. If all of the results of your patient population are reported close to the true value, they would have an average cost of error of about $15. If, however, that population shifts up, the average cost of error would be about $50. This method is producing accurate results with a wider standard deviation. It's a 6 sigma method. It's 6 SD from the mean. This method is more precise, less accurate. It's also 6 sigma. It's 6 standard deviations from the mean, but the cost of error is much higher. Sigma in the medical lab is the allowable error limit minus the absolute of bias divided by the standard deviation. In this case, it equals 6. I've conveniently set the allowable error limit at plus or minus 12 with an SD of 2. If, however, the mean shifts over and the SD goes down, you now have a sigma of 6, but in this case, my cost of error is unacceptable and it becomes a grade F. Existing sigma metrics cannot project the cost of error. I looked at 348 quality control results, measured the cost, and measured the sigma value. These all have sigmas greater than 3, which labs would generally consider to be acceptable. These have costs above $30. A method with a sigma of 8.5 has the same cost of error as a method with a sigma of 3. There is overlap around the 3 sigma mark in both directions. Sigma is not a metric that can be used to measure the cost of error. In the NIST Mayo study, they looked at 89,000 patient records and said, as bias increases, the cost of error increases. That's what they found. We've extrapolated that process mathematically, and these are the results that we found for 56 calcium QC samples. And now that we've got caught up on the background of this, plug your numbers into the computer and watch what happens. Now you can get an overview of your analytes. These are the number of medically unreliable results per year, ranging from 1 to over 500. You can see that most of your methods produce only 1 error per year. This is the average healthcare cost of error. Most of them are clocking in around 18, but not sodium. Are you aware that there's a problem with sodium? If you look at your bias and CVs, the software will tell you which ones need to be improved. If you look at hematology, everything's good in hemoglobins, but pro times INRs, that's another problem. Another cool thing the computer can do is grade the acceptability of your results. Is there an acceptable number and cost of error today? If not, it's a grade F. Stop reporting. Improve accuracy and/or precision as advised. Next question, is there enough margin for error that you don't need to watch it so closely? If not, it's a grade D. Increase your QC activities and improve the method. The next test to pass is your existing daily QC effective to detect unacceptable risk in one run? If not, it's a grade C. Use the process provided by the software. If it is, but you still have false positives, you're a grade B. Use the Catalyst QC software. And if all of these are good, it's a grade A. Grade A methods have acceptable patient risk today and if the method was to fail tomorrow. With risk-based quality grades, you can decide what group of labs or what departments need the most attention. Simply get used to the pattern recognition. Which has the fewest grade A's? Which has the most grade F's? That's where you want to focus your attention. The computer will also tell you the patient results per year, the projected number of medically unreliable results per year, the acceptable number of medically unreliable results per year, the total cost of lab error now, and the acceptable cost of error. Compare these by departments, by labs, by groups. See which analytes require most attention. Now that sodium jumps off the page, which it doesn't do if all you're looking at is a stream of numbers. What do you need to do? Well, improve accuracy, improve precision, or improve the QC process. It will tell you yes, yes, yes. Have you ever heard your staff say, just tell me what I need to do? It will tell you, improve method precision. And in order to improve method precision, these are the things you should check for. See if there are faults in these areas. And if you need to also improve accuracy, then check on these faults too. 348 QC processes were protecting the risk of 12.7 million patients. When they started, they were producing 40,000 medically unreliable results per year at a cost of $266.6 million. After improvement, that 40,000 went down to 21, and $266 million went down to less than $200 million. We did that by improving the accuracy and precision to the average of the acceptable peers, and that reduced the average healthcare cost of error and the number of medically unreliable results produced. That deals with your routine monthly or more frequent method review, which asks, are results good enough now? Currently, that's the evaluation of the analytical process quality, often with sigma metrics or total error versus allowable error. It doesn't currently contain the concept of acceptable risk. Daily QC, on the other hand, you need to be concerned, will staff be notified immediately if good enough becomes bad? How do you evaluate each report batch of patient results using QC charts and rules? Typically within the lab we see this, and in publications we see the risk bells. What we want to do is to bring them all together. A quality control process is a system for monitoring and maintaining a level of acceptability of patient data. It involves the use of QC samples to monitor a measuring system by establishing the mean and SD of a specific QC sample lot and determining statistical limits that will identify unacceptable changes in performance. The right frequency for testing quality control is driven by clinical need and by your patient population, the number of patient samples you test on a regular basis, the acceptable risk criteria. If you want to report 0 errors whenever a method fails, all you need to do is bracket your quality control samples with QC samples using enough replicates of each sample in each run to be sure you're going to detect that failure in one run. There's more to a QC strategy than rules. A full QC strategy involves the frequency of QC events, the type and number of samples, the statistical limits. Notice that they don't say QC rules, the frequency of looking at the QC chart, and the actions to be taken. We've computerized that within Catalyst QC software. This is one example. It is not the final example of this QC strategy. It depends on the margin for error to fail acceptable risk. If your margin for error is higher, you can use a looser QC rule. When your margin for error is very low, you need to use a 1-2S rule as a QC reject. You need to increase your QC frequency and increase the review by the front line and the supervisor. If you do this, those same 348 QC samples can reduce the number of medically unreliable results reported after a failure occurs. So if each of them was to fail, you would report 13,000 errors. You can reduce that to just over 1,000 or to 0 if you want to bracket your results, and you can save $14 million in healthcare costs by improving how you do your QC. The problem with quality control today is that nobody evaluates the ability of QC processes to detect medically allowable error. These words are out of EP 23A, but they are not applied. When I asked people where the QC chart mean and SD should come from, only 65% said individual values for each QC instrument. Others replied the average value from a bunch of instruments, package insert values, or peer report values. Unfortunately, it is common practice to pick and choose different sources for the QC chart mean and SD. That actually invalidates the QC rules you think you're using, and even if you are actually using these rules in the top example, it's still going to take you two replicates to the first reject flag. Risk management is incredibly simple. If you can define acceptable risk and push go, the computer will be able to do all of this. This, folks, is a process that is still in its infancy. It has so much potential to it yet. I am really hoping that you will work with me, contact me, try this out, write about it, study it, put it into place. Let's bring this to the world. if you agree, of course. And now it's time for questions and answers. Let's open up the lines.